Hola.
Hello? Hello?
Aló.
Finbar, we can hear you. How are you? Good afternoon there.
Hola, buenas tardes. ¿Se escucha? ¿Se escucha, Felipe? Hola, buenas tardes. Soy la doctora Jimena Varela. Soy neuropediatra y neurofisióloga de la Clínica Las Condes. Les damos una cálida bienvenida a este segundo webinar de este año, organizado por el Centro Avanzado de Epilepsia de Clínica Las Condes y cuyo objetivo es interactuar con grandes invitados y poder conversar con ellos. Antes que nada, quisiéramos agradecer al grupo de epilepsia refractaria de la SOMNIA por haber incluido este webinar en la actividad mensual de reuniones de trabajo y especialmente a la doctora Lucila Andrade que hizo posible esta inclusión. Nuestro invitado de hoy es el doctor Finbar O'Callaghan, que nos acompaña desde Londres, Reino Unido. El doctor O'Callaghan es neuropediatra del Great Ormond Street Hospital. Él ha participado como autor en las publicaciones del UKIS y en las dos publicaciones del ICSIS, marcando una pauta en el esquema que usamos ACTH espasmo y que actualmente estamos promoviendo vigabatrina y ACTH. Los invitamos a formular sus preguntas en el chat asociado, el que tiene un signo de interrogación en el cuadrante superior derecho, que serán discutidas al final de la presentación en una mesa redonda. Las preguntas se refieren al moderador y no necesariamente van a ser vistas por ustedes. Guiará esta fase el doctor Felipe Castro, neurólogo pediátrico también del Centro Avanzado, y le damos la grata bienvenida al doctor O'Callaghan para que comience su presentación.
Finbar, the floor is yours. Go ahead, please.
Thank you, Felipe. Hello, Felipe, can you still hear me?
Yes, I can.
Okay, and is the slide showing on the screen okay over there?
Yes, it's perfect, so please.
Okay, my apologies, I'm slightly late. I had a clinic this afternoon which unfortunately overran, so I'm sorry we're 5 minutes late starting, but it's my great pleasure to be talking to you today from the UK about my favourite subject, infantile spasms, and to tell you a little bit about what we've done in the UK and what we do in the UK, and some of the research that underlies all that. So, oops. Where am I coming from? My Spanish isn't perfect by any means, but I did hear in the introduction a reference to the studies that I've been involved in before. So initially, early on in my career, I was involved with the United Kingdom infantile spasm study, and then went on later on to lead the ICIS study, the International Collaborative Infantile Spasm Study. And these two studies really inform a lot of what's happened in the UK in the last 20 years in the sphere of infantile spasms, and heavily influence what we do and how we treat our patients. Before we start, just a word about definitions, and definitions always cause confusion, and no more so than the area of infantile spasms and epileptic spasms. So epileptic spasms are the seizure type, and 90% of epileptic spasms are going to occur in infancy. So infantile spasms, if you like, are a subset, but they are the major subset of epileptic spasms. And then people will talk about West syndrome, And West syndrome refers to the triad of features: the seizure type, the infantile spasms, the hypsarrhythmic EEG, and then the psychomotor retardation that accompanies that. So that triad is referred to as West syndrome, which again is a subset of infantile spasms. But there's often quite a lot of confusion about the different terminology. And what we're talking, or what I'm talking about today, is infantile spasms. I'm not going to be talking about epileptic spasms outside of infancy, although we can talk about that in the discussion if you want to later, but predominantly going to be talking about infantile spasms. Another key component or key thing that we need to understand is the concept of the epileptic encephalopathy. And a key component of that concept, according to Ingrid Scheffer and the ILE classification team, is that amelioration of the epileptiform activity may have the potential to improve the developmental consequences of the disorder. And that's important when we start thinking about the treatment of infantile spasms, that actually, if we treat rapidly, are we going to make a difference, and treat effectively, are we going to make a difference to the outcome for these children? And that's still open to debate, but I think there's some suggestive evidence, certainly, that if we do treat effectively and swiftly, we may have an impact. And infantile spasms are one of a number of epileptic encephalopathies that affect the young child. And it's, if you like, there's this terrible progression from early epileptic encephalopathy of infancy, Ohtahara syndrome, early myoclonic encephalopathy, MPSI or migrating focal seizures of infancy, West syndrome, Dravet syndrome, Lennox-Gastaut syndrome. And you can have a child that progresses from an early epileptic encephalopathy of infancy through to West syndrome, through to Lennox-Gastaut syndrome, in a kind of disastrous trajectory through infancy, through these different epileptic encephalopathies. So I thought we'd kick off, if I can, just to hopefully show you a video, although at the moment I'm having difficulty showing this to you. I think we'll pass on for that. Well, that was going to show you a classic example of a child with infantile spasms, but I'm sure you've all seen that many times. Now, what often goes with the infantile spasms is the hypsarrhythmic EEG, the chaotic, non-rhythmic, asynchronous, high voltage EEG, which we see in these children. This hypsarrhythmic pattern most frequently occurs during non-rapid eye movement sleep, so non-REM sleep, often just before waking or arousal. And the hypsarrhythmic pattern is greatly reduced during REM sleep. And there can be variations on the hypsarrhythmic pattern. There can be increased periodicity or interhemispheric synchronization. There can be asymmetry, or there can be a consistent focus of an abnormal discharge. There can be episodes of attenuation. You can have high voltage bilaterally asynchronous slow activity, and you can get fragmentation of the hypsarrhythmia. So there are variations on the classical pattern of hypsarrhythmia, but I think a severely abnormal EEG in conjunction with infantile spasms gives you your diagnosis. And here's an example of the high voltage chaotic hypsarrhythmic EEG. This is an interictal pattern. This is occurring in between the spasms. And you know, in terms of recognizing this hypsarrhythmic EEG, you can almost turn it upside down, as I've done here, and it looks the same. Okay, this chaotic pattern is almost indistinguishable when you turn the EEG upside down. You can, of course, get hemihypsarrhythmia, as shown here, when you have unilateral hemispheric pathology, and you might see a hemispheric or a hemihypsarrhythmic pattern. And then, of course, during the spasm, the EEG will change, and quite often you will get this electrodecrement during the infantile spasm. So you have the the chaotic hypsomanic pattern very often ends with a slow wave and then an electrodecrement, and when the child is actually having the spasm itself. So that's the EEG, or briefly about the EEG and spasms. I want to just say something about the EMG, which I think is also useful when you're trying to make this diagnosis. The ictal EMG in infantile spasms has a characteristic rhomboid or diamond-shaped discharge. And it's useful because this tells you definitively when the spasm is happening. The EMD discharge will often correspond with that slow wave that I just pointed out before the electrodecrement. And although the spasms may look phenotypically homologous, they may all look identical, you may often find on the EMG that there are different patterns of muscle activation or muscle group activation with different spasms in the same child. So this is the diamond shape that I'm trying to point out to you. And unfortunately, my pointer isn't working, I'm afraid. But you can see on the left of your screen the discharge predominantly starts off in the right deltoid with one spasm, and then on the right of your screen, it's predominantly starting off with the mylohyoid. So it's showing you that different muscle groups may activate at the start of an infantile spasm or initiate the spasm within the same child, within the same cluster of spasms. But look for that characteristic diamond shape or rhomboid shape EMG discharge to tell you when the spasm is happening. Now, one of the key things about the concept of the epileptic encephalopathy is that the thought is that the longer the encephalopathy goes on, the more damage it does. And the logical corollary of that is that if it takes you longer to treat, then the child will do worse developmentally, because it's taken you a lot. The epileptic encephalopathy has persisted for a longer period of time. So we define this with a concept of lead time to treatment, and we all know that this occurs. So the spasms will begin at a set point in time. It may then take some time for the parents to ask for help. It may then take some time for the clinicians to make a clinical and an EEG diagnosis. And that lead time to treatment can be quite variable from a number of days, or sometimes up to a number of months, depending on how swiftly the parents ask for help and how swiftly the diagnosis is made. And of course, there's a further lag time between when the diagnosis is made and when effective treatment starts and spasms stop. But this concept of lead time to treatment is important. And why is it important? Because it relates specifically to developmental outcome. So this is data taken from the IKIS study. And what this is showing on this table, as you go down the table, you're going through different lead time categories. So the first category was less than 8 days, second category 8 to 14 days, then 15 to 28 days, 29 days to 2 months, and greater than 2 months. And what you can see in the next column is that the developmental score, as measured by the Vineland, is decreasing with each increasing category of lead time. So the longer the lead time, the worse the children were doing developmentally in the IKIS study. And I think other people have replicated that kind of finding. So lead time, the time it takes to diagnose these cases, the time it takes to start effective treatment really matters, because it has an impact, or seems to have an impact, on developmental outcome. Another thing which is encouraging and is worth noting is that we're getting better at this. That lead times, or certainly in the UK, and I'm sure the same is true in Chile and other countries in South America and North America, that actually we're getting better at diagnosing and treating faster. So the UKIS study, which was the preceding study, only 14% of children had a lead time of less than 8 days, whereas in the ICIS study, 29% of children had a lead time of less than 8 days. In the UKIS study, 27% of children, it was over 2 months before treatment was initiated, whereas in the ICIS study, luckily, this is halved, and only 14% of children, it was taking over 2 months. We also need to be aware of something called diagnostic overshadowing. What became clear when we looked at the ICIS data was that if you had a high risk of developmental impairment, so those children who perhaps had a history of birth asphyxia, or they had already diagnosed chromosomal abnormality or an underlying metabolic problem, they're at high risk of developmental impairment. It took them longer to be treated than if you're at low risk or a child who didn't have an underlying problem already diagnosed. So it did appear that those children, for whatever reason, where we'd already had a diagnosis of that something was going to impact on development, it took us longer to diagnose the spasms or to treat the spasms in those children. 2/3 of the children in the category of greater than 2 months had a higher risk of developmental impairment compared to 1/3 with a low risk of developmental impairment, whereas in the shorter lead time categories it was more 50-50. So beware of the fact that those children who already have an underlying problem, or we've diagnosed with underlying problem, beware of the fact spasms may develop. They still need to be treated swiftly. Etiology of spasms, we're generally finding in about 2/3 of cases we'll find an underlying neurological disorder in children with infantile spasms. Now that neurological disorder may or may not be known at the time of presentation. When you start treatment, you may well not know the underlying diagnosis, the underlying neurological disorder, because you haven't got the results back from your genetic testing. You may or may not have done your MRI scan. So, but eventually, and in ICIS it was certainly the case, 2/3 we were able to diagnose an underlying neurological disorder. So when reporting on children with spasms, we classify etiology when all the results are available. And just to ram home that point, all this information is not available when we start treatment. So we can't really tailor treatment at the point of we diagnose spasms according to what the etiology is very often. It's all very well talking about precision therapies that we may be able to use in the future because we know the genetic diagnosis, but frequently the spasms are starting before we've got that information, and we have to start treatment before we know the etiology. So there are numerous etiologies of infantile spasms, and these I'm listing the kind of etiologies that we may see. In Europe, certainly the single most common etiologies were trisomy 21, Down syndrome, and tuberous sclerosis complex. In the developing world, in India, Sri Lanka, where we've collaborated with Sri Lankans in their study of infantile spasms, hypoxic ischemic encephalopathy and neonatal hyperglycemia were the most common symptomatic causes of infantile spasms. But there are a plethora of different causes, and I've just listed some of them there. Obviously, there are genetic causes. Now, there are syndromes of genomic imbalance. Miller-Dieker syndrome, trisomy 21, we've already mentioned, Pallister-Killian syndrome, Williams syndrome. These are relatively well-known causes of infantile spasms, which are syndromes of genomic imbalance. Miller-Dieker syndrome, very high incidence of spasms in that syndrome. Trisomy 21, about 5% of Down syndrome children will go on to develop infantile spasms. Deletion of 1p36 is another syndrome associated. About 1/5 of those cases go on to develop infantile spasms. And then, of course, there are single gene associations, and we're getting to know more and more about these all the time. So Liston-Kefley syndromes, DCX, LIS1 mutations, ARX mutations, mutations CDKL5, STXBP1, duplication of FOXG1, so on and so forth. You will all be aware of and know of different single gene disorders which have gone on to develop infantile spasms. And again, I've just listed some of the more commonly found ones there. So this is just breaking down what we found in ICIS in terms of the proven etiology. As I said, about 2/3 of cases in ICIS, we found an underlying etiology. And we categorized them into whether these appear to have happened or prenatally, perinatally, or postnatally. And you can see again, genetic disorders were a significant proportion. We did have some hypoxic ischemic encephalopathy and hypoglycemia. We did have some metabolic disease, and stroke is another interesting cause. So stroke around the time or shortly after birth being associated with the development of infantile spasms. And I'll say a little bit more about that in a second. Were there changes over time in terms of the etiology between UKIS and ICIS? And there was a little bit of change. So in terms of hypoxic ischemic encephalopathy, perhaps encouragingly, the frequency appeared to have decreased between UKIS and ICIS. So the more recent study, only 6% of our cases had a history of hypoxic ischemic encephalopathy. But interestingly, and I'm not sure I can completely explain this, that Down syndrome, we had a higher frequency of Down syndrome in the ICIS study than we did in the UKIS study. Now that may reflect something about the fact that ICIS was an international study, and there may be differing rates or differing ways in which Down syndrome pregnancies are managed between the UK, Germany, Switzerland, Australia, New Zealand, which were the different countries that took part. But certainly we saw more Down syndrome cases in our infantile spasm cohort in the ICIS study than we did in UKIS. So just briefly recapping the UKIS study, just for revision. The UKIS study was a multi-center randomized parallel group open control trial that we conducted in the UK in the early 21st century. And it compared hormonal treatments, prednisolone or tetracycline depot, and tetracycline depot was a synthetic ACTH, and we compared the hormonal treatment with vigabatrin. And there was a randomization between prednisolone and tetracycline depot. And very briefly, what the UKIS study showed was that in terms of primary clinical outcome, cessation of spasms at day 13 and 14, the hormonal therapy was superior to vigabatrin. About 73% had a primary clinical response on hormonal therapy versus 54% on vigabatrin, and that difference was significant. When we went on to look at development, however, at 14 months of age, there was no significant difference between the hormonal therapy and vigabatrin group in terms of developmental outcome. However, and this is important, there was a significant etiology treatment interaction. So hormonal therapy was associated with a significantly better developmental outcome than the vigabatrin group in that group of children where we couldn't identify an underlying etiology. So the no identified etiology group, it appeared that hormonal therapy was associated with a better developmental outcome than vigabatrin. It was because of these two findings that we went on to ICIS. Before I just mentioned the ICIS study, just to say we did do a comparison between prednisolone and the synthetic ACH in the UKIS study, and we found no difference in terms of response. That may be different in the ICIS study as we come on. So the hypothesis behind the ICIS study was that, okay, we had children who'd responded to hormonal therapy, but we'd also noticed that there were children who hadn't responded to hormonal therapy, who as soon as you switched them to vigabatrin, then responded, and vice versa. Children who hadn't responded to vigabatrin in the UKIS study, and as soon as you switched them to hormonal therapy, they then responded. So we came up with the idea that if you combined hormonal therapy and vigabatrin from the start, that you would get a superior response to just using hormonal therapy alone, both in abolishing spasms, but also with developmental outcome. So children were randomized in ICIS to combination therapy. That was prednisolone or synthetic ACTH plus vigabatrin versus hormonal therapy alone, which was prednisolone or synthetic ACTH. The doses that we used were the same doses that we used in the UKIS study. So prednisolone, initially 40 milligrams per day, increasing to 60 milligrams per day at day 7 if there was no clinical response. Synthetic ACTH depot, 0.5 milligrams or 40 international units on alternate days, increasing to 0.75 milligrams per day at day 7 if no response. Vigabatrin, 100 milligrams per kilogram per day, increasing to 150 milligrams per kilogram per day at 72 hours if there was no response. Length of treatment. Hormonal therapy was a short, intensive burst of treatment for 2 weeks at high dose and then a wean over 2 weeks. And after 4 weeks, they were off hormonal therapy. Vigabatrin, we advocated 3 months of treatment and then a wean over 1 month at the end of 3 months of treatment. The main outcomes in the ICIS study were cessation of spasms. Everybody's interested in stopping the seizures, but we were more stringent in the ICIS study. If you remember in the UKIS study, we just said we want to see spasms stopping on day 13 and 14, for a 48-hour period. In ICIS, partly because of what we found out following a Delphi consensus process, we had a 4-week, we defined cessation of spasms as being spasm-free for 4 weeks from day 14 to 42. So a much more stringent definition of response. We had an electroclinical outcome, which was cessation of spasms and resolution of hypsarrhythmia. And then we had developmental outcomes at 18 months and 3.5 years. In terms of mortality and serious adverse events, the really good thing is that we had no deaths in the study that were attributable to treatment. There had been a worry that using high-dose hormonal therapy, there may be an association with severe infection and possible mortality, but we did not see any deaths that were attributable to any of the treatments in the ICIS study, which I think is important. There were 377 kids in the ICIS study, so a large cohort by the standards of infantile spasm study, and no deaths attributable to treatment. And really the adverse reactions were fairly equally distributed between the different groups. And these are the headline findings from the ICIS study, which hopefully many of you will be aware of. In terms of the clinical response, the cessation of spasms, day 14 to 42, combination therapy was significantly better than hormonal therapy alone. We had a close to 72% response on combination therapy versus 56–57% response on hormonal therapy alone. Not only that, they responded quicker on combination therapy. Usually by 2 days of therapy, you'd stop the spasms, whereas on hormonal therapy alone, it took 4 days. And again, that was a significant difference. Now, this table I've put up just to try and put the ICIS study in context with the other studies. Now, part of the problem is that in ICIS, we used a much more stringent definition of response, this definition of no seizures between day 14 and 42. But if we use the response or the definition of response that's been used in UKIS and used by other studies, the Sri Lankan study of Wanigasinghe, Vijayavano's previous study comparing vigabatrin and ACTH, where they all used a cessation of spasms by day 14 as their criteria. If you compare those, you can see that the ICIS study, you were getting dramatically different or improved responses on combination therapy. So 90% plus of children on combination therapy, spasms had stopped at day 14, according to the old criteria for defining response. Now, some of those did then have breakthrough spasms. So that's why when we use the day 14 to 42 response, the 4-week response definition, that the response rate fell down towards 70%. But actually, if you're trying to compare all the different studies that are out there, ICIS combination therapy is dramatically more effective than any of the other results that you're seeing in those studies. What about electroclinical outcomes? So this was abolition of spasms for that 4-week period plus resolution of hypsarrhythmia. Again, combination therapy was better than hormonal therapy alone. And that's a significant difference, not quite as dramatic as just the clinical response, but again, definitely a better response on combination therapy, 67% versus about 55%. And even in those children who had a proven underlying etiology, it does appear that combination therapy was doing better than hormonal therapy alone, although it didn't quite reach statistical significance. So 62% on combination therapy versus 53% on hormonal therapy alone. Were there any specific etiological groups that did better? And in the proven etiology groups, and I would just put this out there for discussion really, but in the children who had an underlying stroke as the presumed etiological cause of their spasms, that they seem to do particularly well in this study. So 82% of our kids who had stroke and infantile spasms had a clinical response, okay, which was far better than all the other proven etiologies. So it may be that children with stroke as a cause to their infantile spasms do better. And it may be because with a stroke, you've just got a single focal hit, which has caused some focal pathology in the brain, but the rest of the brain may be entirely normal. And it may be that's why that particular etiology is associated with a better prognosis than other proven etiologies for the infantile spasms. So what about, so I said that the basic comparison had been between combination therapy and hormonal therapy alone, but of course we had different treatment regimes in the study. And we had prednisolone given alone, we had tetracycline given alone, we had prednisolone plus vigabatrin, we had tetracycline plus vigabatrin. And if this table is comparing the results versus prednisolone alone, so you can see from this, if you look, that the synthetic ACH, the tetracycline and vigabatrin, that their chance of a good response was significantly better than the prednisolone alone, 3.5 times as likely to get a response on synthetic ACTH plus vigabatrin than you would be if you just had prednisolone alone. So it's important, there's a suggestion here that, or more than a suggestion, that the best combination may be the synthetic ACTH plus vigabatrin. The caveat to that is that within the ICIS study, we allowed a degree of parental choice as to what hormonal therapy they had. And the majority of parents actually chose prednisolone. So there was, if the parents didn't choose, we did randomize, but actually that may have introduced an element of bias, which means we have to treat these results with some caution. And the same is true, this is just looking at the electroclinical outcomes as opposed to just the cessation of spasms. Again, it's suggesting that the combination of ACTH and vigabatrin may have been the best combination. So what about developmental outcome then? We've shown combination therapy was more effective at stopping the spasms. Did that then go on to mean that there was a better developmental outcome? This is slightly puzzling, and some of you may have seen this data before and read up about it. But in terms of if you were a responder had a clinical response in ICIS, i.e. you'd stop spasming at day 14 to 42, you are much more likely to have a better developmental outcome. And that's what this graph is, or these box and whisker plots are showing you. So your developmental score was, or the median developmental score was 78 in those who'd had an early clinical response versus 61, a 17-point difference if you hadn't had an early clinical response. So it does appear getting an early clinical response implied you're going to have a better developmental outcome. And despite the fact that we knew combination therapy was going to mean you were more likely to get an early clinical response, when we actually looked at the two treatment modalities and related those to developmental outcome at 18 months, we saw no difference. So literally no difference between the combination therapy group and the hormonal therapy alone group in terms of their developmental outcome at 18 months. And that is a bit of a puzzle, and we can discuss that in questions if you want to later on. This is just graphically showing you what I'd shown you before in the table, that lead time is critically important. So these are the different lead time groups, and you can see that on the y-axis we have their developmental score, and you can see that it's falling down with each increase in lead time group. Lead time is also important in terms of the epilepsy outcome. So if you had a longer lead time, you were more likely to have spasms at 18 months than if you had a shorter lead time. So lead time was not only associated with a better developmental outcome, it was associated, shorter lead times were associated with a better epilepsy outcome as well. Does early etiological diagnosis improve outcome? Well, this comes back to the point that I was making at the beginning of the talk, that I think obviously the way forward in terms of our treatment of all epilepsies, and infantile spasms are no different, it's going to come with precision therapies. And I've given you, I've just quoted Lemke's paper on GRIN2B mutations and how he tried a treatment specifically targeting the problem with GRIN2B mutations and NR2B receptor blocker, and got a positive result. And it may be that precision therapies are the way forward and where we're going to get dramatic improvements in therapy. But I come back to the point that at the time of the onset of spasms, at the moment, we frequently don't have the etiology diagnosis. We don't have the results from the genetic testing. So at the moment, we're still having to resort to the treatment approaches that we've currently got. Surgery, I think that is important to think of, particularly in cases of tuberous sclerosis and infantile spasms. It may be that actually you can identify one significant tuber, which you can see in the right frontal lobe on this child. This child presented with devastating epilepsy in the first 2 months of life, had tuberous sclerosis, had this large right frontal tuber, which we removed early. It stopped the spasms and the other focal seizures the child was having, and they've been seizure-free ever since. So do consider the possibility of epilepsy surgery in your tuberous sclerosis patients. Does early etiological diagnosis alter our treatment strategies? So sticking on the issue of tuberous sclerosis complex, you'll recently have seen papers come out from Josiak's group in Poland and the EPISTOP trial, suggesting that if you've got a child that you know has got tuberous sclerosis, that if you do screening EEGs early on in life and see an epileptiform abnormality on the EEG, and start, as soon as you see any abnormality on the EEG, start prophylactic vigabatrin, are you going to improve the outcome, as opposed to the conventional approach of waiting to see whether they develop clinical seizures or not and then treating. I think The EpiStop study has shown that yes, you will delay the onset of epilepsy if you take the prophylactic approach, but there doesn't appear to be at the moment, again, any improvement in development, certainly at 12 months in their study. If you know you've got a severe underlying pathology, if you have made a diagnosis of a severe underlying pathology at the time of diagnosis, for example, this child had a devastating hypoxic ischemic encephalopathy, that may alter your treatment strategy. You may think, actually, in this case, they're so damaged, I'm not so worried about the prolonged effect of the infantile spasms, and I'm going to try just using one treatment at a time rather than potentially exposing them to 2 treatments at the same time. And that's a reasonable approach. But just remember that in the ICIS study, even in those kids with a proven etiology, combination therapy was more effective, or appeared to be more effective than monotherapy with hormonal therapy. Does early etiological diagnosis improve prognostication? I've already shown this slide, that with stroke, I think we can be, it does appear to me that we can be fairly confident that we may get control of the spasms. But for other diagnoses, I'm not so sure. Lemke's group studied, looked at the issue of whether finding a genetic diagnosis would help you in terms of prognostication. So he studied 45 children with West syndrome. He excluded those cases with tuberous sclerosis and Down syndrome or an acquired pathology like hypoxic ischemic encephalopathy. And he looked using an epilepsy gene panel, which contained 131 genes, for disease-causing mutations. You know, the common genes that we would look for, the CDKL5, ARX, the mTORopathy, DEPDEC5, SCN1A mutations, KCNB1, and he found 11 disease-causing mutations out of the 45. In a further 2, they discovered a duplication on chromosome 2, which included SCN2A and SCN3A. And what this small study showed, or it purports to show, is that outcomes significantly worse in those with an identified gene disorder versus the others. Severe developmental disorder was more common in those where they had an identified gene disorder. There was worse refractory epilepsy, and there was more cerebral atrophy on MR imaging. So, our conclusions. EUCAS established the superiority of hormonal treatments over vigabatrin in stopping spasms at day 14. That was clear. ICIS established the superiority of combination therapy over hormonal therapy alone at stopping spasms between day 14 at day 14, but also for a prolonged period between day 14 and 42. Early response to therapy is really important for developmental outcome. If you get an early response to therapy, you can be more confident of a better developmental outcome. Shorter lead times are really important for both the developmental and epilepsy outcomes. And there is a suggestion from the ICIS data that the combination of ACTH and vigabatrin is perhaps the most effective combination. Just want to acknowledge my collaborators, research collaborators on the ICIS and the EUCAS study. And you can see them listed there. I particularly highlight John Osborne, who was my initial PhD supervisor, a great friend, and has done amazing work in the UK, not only in infantile spasms, but in tuberous sclerosis. Is now long retired, but still very much alive. And then national collaborators, or our international collaborators in Australia, Mark Mackey, Melinda Nolan in New Zealand, Dietz Ratig in Germany, and Bernhard Schmidt in Switzerland. And those were our funders. And I leave you with a picture of UCL. So Felipe, if you're feeling nostalgic, there's a picture of University College London for you. And I'm very happy to take any questions. And apologies again for being slightly late at the start.
Agradecemos al doctor Callaghan por su brillante presentación. Y ahora procederemos a la sección de preguntas y respuestas que ustedes han formulado y aún pueden formular a través del chat. Well, we truly appreciate your brilliant presentation, Dr. Callaghan, and now we will proceed with the questions and answers section. So, the first question will be one of my own. At the beginning of the presentation, you described the classical definition of epileptic encephalopathy. However, in the 2017 consensus of epileptic syndromes, this was slightly different, adding this idea of the developmental and epileptic encephalopathy, which both mention that both the underlying etiology and the inter-ictal epileptiform activity could contribute to developmental impairment. So the question is, in which cases would you say that epileptic spasms may behave as a true epileptic encephalopathy, and in which cases would you consider that it could behave rather as a developmental and epileptic encephalopathy, and hence the outcome could be poor even though you start treatment very early?
Yeah, I mean, okay, so it's a really interesting, I mean, I'm totally in agreement with the reclassification that the ILE have given, and that I think it's trying to incorporate the fact that the underlying etiology has an impact, obviously, on development, as well as the epilepsy. So a classic example would be tuberous sclerosis complex, you know, or some of the other genetic conditions. But let's think about TS. So you have a disorder which is well, in every cell of the body you have a dysfunction of the mTOR pathway. You also have structural pathology in the brain, all of which is like, and we know the greater the structural pathology in the brain, the worse the developmental outcome. So that's clearly important. But additive to that is the infantile spasms. So in tuberous sclerosis complex, if you look at outcomes or intellectual outcome, it's indisputably that the genetic disorder and the structural pathology has an impact. But also, if you manage to avoid spasms and epilepsy in the first 2 years of life in TS, then your chance of having a good developmental outcome is much higher. So I think clearly, I think both are important, and I think it's probably impossible to try and disentangle it, but you still have to treat the epilepsy. You still have to treat the epileptic encephalopathy, and some of the acquired disorders. And I alluded to hypoxic ischemic encephalopathy or birth asphyxia. If you have a severely damaged child because of birth asphyxia, then it may be debatable how much the spasms or the epilepsy add to the kind of developmental or intellect or cognitive hit that's going to occur, and you may want to be more relaxed in your treatment approach. But generally speaking, the clues in the name, developmental and epileptic encephalopathy, you still have to think of the epilepsy.
Muchas gracias. La doctora Francisca López pregunta si mejor hay respuesta clínica de los espasmos, pero el electro sigue con hipoarritmia. ¿Qué hacer en esos casos? Dr. Francisca Lopez, sitting just next to me, is asking, in case you have a clinical response, you have a spasm cessation, but you still have hypsarrhythmia in the EEG, what do you do? How do you proceed? Do you change your treatment? Do you escalate to the next step?
Okay, so if there's genuinely been a clinical response, so you've had a prolonged video EEG and you're confident that you're not seeing any clinical spasms, sometimes the hypsarrhythmia takes longer to resolve than you see the clinical spasms. I would then repeat the EEG at a given period later, 5-7 days later, and you may well find that the hypsarrhythmia is then resolved. But I am of the opinion that I want the hypsarrhythmia to resolve. So I wouldn't be comfortable just stopping treatment if I knew there was persistent ongoing hypsarrhythmia. But that's a personal view. Other people may disagree with that. But.
No. When do you recommend to use both therapies together? This is vigabatrin and steroids, and what's your dose? What's the dose you use, and how long do you use vigabatrin once the spasms have already stopped?
Okay, so I use combination therapy from the start in the majority of the children. So you were with us at Great Ormond Street, and I'm not sure whether you were with me when I saw kids with infantile spasms, but I will start combination therapy at the start, because almost invariably it is stopping the spasms. And I use the ICIS protocol, so I will use the doses that we used in the ICIS study, and I usually use the same duration of treatment. I'll certainly try and get them off hormonal therapy by 4 weeks, and I'll usually try and wean them off the vigabatrin from 3 months. The only exception to that might be in cases of tuberous sclerosis complex, where I might continue the vigabatrin for longer.
Excuse me, dear Firma, I would like to ask you something. There is a lot of questions from the audience about the association between vigabatrin and corticosteroids related to the adverse effect using both. You have a publication named An Investigation into the Relationship between Vigabatrin Movement Disorder and Brain Magnetic Resonance Imaging Abnormality in children with infantile spasm. I would like you to talk about this topic because it's a very important question everybody is doing to you. And the other paper that I told you, we talk about that by mail, about the 3 cases of fulminant adverse effect with a combination, even with a patient with a death. You know?
Okay, so first of all, we know that in a certain number of patients who are treated with vigabatrin, that we get MRI abnormalities in the brain. That these if you see them, they're obviously quite worrying, because they tend to be in a distribution that's similar to you might see with mitochondrial disease, the high energy areas in the brain, so in the basal ganglia, in the brainstem, dentate nuclei in the cerebellum. So you see these abnormalities on MRI scan in some of the patients treated with vigabatrin. They appear to be transient, so they appear to resolve over time. But there has been a question, and understandably, are they associated with movement disorder that sometimes you may see with children with infantile spasms? And I don't know a definitive answer to this question. We looked at this in the ICIS study, and whilst we did see the vigabatrin associated abnormalities in the brain, we couldn't conclusively prove that they were associated with a movement disorder, but they may be. And clearly, if you see those abnormalities in the brain and you see a child who's got a florid movement disorder, myself, like you, would probably take the child off the vigabatrin at that stage. More important question is the paper you talk about, in which the 3 cases, I can't remember which part of the US the paper comes from, 3 cases in which they talk about a fulminant problem associated with combination therapy. Again, I can't definitively answer that question, but all I would say that in 377 cases in the ICIS study, we didn't get any examples of this. And as I showed you the adverse event data and the serious adverse reaction data. And also, if you look at the 3 cases in that paper, and they did not receive combination therapy according to the protocol that we were using in the ICIS study. That actually they got a combination of steroids and vigabatrin, but not in exactly the same protocol as we used in the ICIS study. So I think I'm still confident to you at the moment until I see evidence, otherwise, using the ICIS protocol, using a short course of steroids, okay, weaned off after 4 weeks, using vigabatrin in the way that we use in the ICIS study, I would be confident to use that combination therapy. I think in the cases, if you delve into the 3 cases in the paper from North America, they weren't receiving that according to that protocol. I think they were very often getting longer courses of steroids.
I think you have already said this, but someone is asking whether you have to expect the 3 main features classically described for West syndrome, or you could diagnose epileptic spasms without the classic triad.
I think that you can, yes. And the EEG doesn't have to be hypsarrhythmic, but it does have to be significantly abnormal. But yeah.
What if the background activity is normal? What if you still have epileptic spasms, normal development, but you have an EEG with maybe occasional interauricular form activity, but normal background? Would that still qualify as epileptic spasm syndrome?
I think very early on in spasms, you can get EEGs like that look relatively normal background if you catch it very, very early. I think obviously the important point, you have to get a period of sleep and non-REM sleep on your EEG. So people have been fooled by just getting EEGs while the child's awake. But I think actually in a child that has infantile spasms, that the EEG will develop and become severely abnormal over time. So it's possible it looks better at the start, and it's possible it may look better than you expect if all you're getting is when the child's awake. But I'd be slightly worried about if the EEG remain persistently looking benign and making the diagnosis really.
Once the patient is already resistant to steroids and vigabatrin, what's the next step? What would be next suggestion?
Yeah, I know, the $64 million question. So the next step, I tend to try, I'm quite a fan of the ketogenic diet in this scenario, and would try the ketogenic diet if that's possible. I think there is some encouraging results using the ketogenic diet in refractory spasms, and it's a relatively easy, it's not that easy, but in terms of it's easy to give the ketogenic diet to an infant as opposed to giving it to a 5-year-old. So I would think about the ketogenic diet as my next step really.
Well, someone's asking what to do when you don't have prednisolone available. So because in Chile we have ACTH and we have methylprednisolone and most of oral steroids, but for some unknown reason we have no prednisolone available. So what would you do in that case? Is there any alternative?
Well, the trouble is I'm not an expert in steroids pharmacology, so what would be the equivalent oral steroid to prednisolone? I would look into, because I don't want to say something that's inaccurate, because I'm not aware of, because prednisolone is so available in the UK. But you've got synthetic ACTH, and I have to say the results from ICIS did suggest that synthetic ACTH plus vigabatrin was the most effective combination, and I would be tempted to give that. I think there's a certain amount of parental anxiety or dislike of the injections that are associated with giving synthetic ACTH depot. But actually, if you explain to them how encouraging the results look, then I think it's possible to persuade parents that that's a reasonable course of action. Of course, in the States, that's all they'll use is ACTH. So, or virtually universally, they all use ACTH rather than prednisolone.
In a patient with epileptic spasm amenable to surgery, would you still start steroids and vigabatrin and then he could undergo surgery, or would you suggest surgery straightforward?
Well, sometimes, in my experience, it takes some time to persuade the neurosurgeons that what you're suggesting is the right course of action. So I would inevitably, I think you're going to have to start treating before you get the surgeons to stand up and take responsibility for operating on an infant at this age. So, and then of course there's an argument: do you want to use, if you're waiting for surgery to happen, do you want to use steroids at that stage, or would you just use vigabatrin while you're waiting for the surgery to happen? And that would be a reasonable approach. But I raise the issue because we've had that case that I showed you, and there have been other cases in the literature that you can actually stop the spasms, and extremely effectively with appropriate surgery. So do consider it. It's not, it's only going to be in a very small number of cases it's ever a reasonable option, but it is an option that we should think about.
Okay. Someone is asking whether the adverse reactions to vigabatrin have anything to do with how fast you start the drug.
I don't. In terms of the short term, if you're talking about the MRI abnormalities associated with vigabatrin, the answer is I don't know if there's any relationship with the speed at which you escalate the dose. But I think there is an argument that you want to escalate it relatively swiftly to try and stop the spasms. But in terms of long-term consequences of vigabatrin therapy, the retinal problems that we worry about, that there is some evidence that that's associated with total cumulative dose. So the length of treatment becomes important at that stage, and which is why we recommended that you treat for 3 months and then weaned off after 3 months, after over a month, with the infantile spasms cases. So length of treatment may be associated with long-term side effects of vigabatrin. I don't know whether swift escalation at the beginning is any more associated with the brain MRI scan abnormalities or not.
How long do you keep vigabatrin, or to be more precise, in which cases would you keep vigabatrin for a longer time? Which patients?
So I suppose the group that I would be the TS group. Okay, I'm so worried about seizures in the first 2 years of life in tuberous sclerosis that I would probably continue with the vigabatrin for that first 2 years. And I know that's a long time, but if you can avoid seizures in the first 2 years of life with tuberous sclerosis, your developmental outcome is so much better that I think it's worth it for that group. Okay.
In refractory spasms without recognized etiology, either structural or genetic, do you recommend palliative surgery? I suppose the one who wrote this is thinking of VNS or corpus callosotomy. Would you recommend palliative surgery in these patients?
Not destructive palliative surgery. I wouldn't generally. I've never gone down the route of doing callosotomies in kids with spasms. Vagal nerve stimulator. I don't know. I'm slightly ambivalent about the vagal nerve stimulator. We tend to do it, don't we, in a lot of patients where we've reached the end of the road. There's not a resective surgical solution, and we say, well, we can put the vagal nerve stimulator in. and very rarely do we see a dramatic reduction in seizures on the vagal nerve stimulator. I hope I'm not offending anyone there. So yes, you can try it, but of course an infant who's having infantile spasms may not be of a size that you can get a vagal nerve stimulator. You know, they may be too small for a vagal nerve stimulator, although they're getting better and better at reducing the size of the battery. But personally, I'm not a fantastic enthusiast of vagal nerve stimulation.
Once you have finished ACTH cycle, do you suggest to taper with prednisolone with oral steroids?
So sorry, I should have probably made that clearer. In the ICIS study, we gave ACTH for the 2 weeks, and then we weaned them off the ACTH with prednisolone for 2 weeks, or another steroid. So for the weaning period, we switched to an oral steroid. But so yes, that's sensible, and that's what we did.
Why? ¿Después del tratamiento o?
No. What's the rationale of tapering? Is that associated with a better long-term outcome? What's
the associated is as we do with all, I mean, in other disease situations, if we giving courses of steroids, we tend to taper, because of our worries about the effect on the adrenal suppression with high dose steroids. So we tend to taper. Whether it would be safe to just stop after 2 weeks, I don't know, but we've always tapered. So that's what we do.
In the case of a patient who has solved the spasms but still continues with a persistent interictal epithelial activity for an underlying etiology, for instance, could you add another anti-seizure medication, or would you be just happy with the clinical response and the resolution of hips?
Generally, I'm happy with the clinical response and resolution of hypsarrhythmia. It's a difficult question. You know, am I going to? You know, there's an underlying etiology that's associated with epilepsy. That you stop the spasms, the hypsarrhythmia is resolved, but you know there's still a high risk of epilepsy. Should you just continue an anti-seizure medication? I don't know if there's a definitive answer to that. Sometimes I do, sometimes I don't. I mean, I've not got a definitive answer. I think you have to judge it on each individual case by case basis. But I'm not going to criticize you if you think this child's got underlying genetic disorder. We stopped the spasms, we stopped the hypsarrhythmia, but I still think there's a high risk of epilepsy. Therefore, I'm going to switch to another anti-seizure medication as protection. Lots of people do that, and I think that's reasonable. And as I've already alluded to, I tend to do that with my tuberous sclerosis patients.
We are running out of time, so this will be the final question. So someone is asking about surgery in TSC. How do you identify the most important tuber, considering that in these patients, because of their age, both the clinical and the EEG are not localizing? So.
Yeah. So in the very young infants, it can be difficult. Sometimes the EEG is localizing or lateralizing. So in that case that I showed you with that large right frontal tuber, we did see lateralization of the EEG abnormality. But I agree it's more difficult. But if there is such a clearly dominant intracranial pathology, as in that case, and indeed in the other cases that I've operated on, I've been involved in the neurosurgical process, that usually there is a very dominant intracranial tuber, and there usually is some hint from the surface EEG that it's lateralizing to that side.
Final question, what's the role of PT? Is it modified because of the hypsarrhythmia, even in patients with structural abnormalities?
I haven't done PET in this scenario, so I haven't done PET in infants in this with spasms. We haven't gone down that route. The role of PET in TS surgery is, Harry Shigani published some years ago about the usefulness of AMT PET in tuberous sclerosis complex, and produced extremely promising results. But the problem is no one else has got the alpha methyltryptophan ligand to use. So actually, it's not in widespread use. FDG PET can be useful sometimes in older patients with TS in terms of helping to localize the epileptogenic region, but I've never used it in infants at this age.
I think that's it. So we truly thank your very kind participation and your readiness to join from London, UK. Así es que agradecemos a todos los asistentes por su participación y presencia hoy, y en particular agradecemos al Dr. Finbar O'Callaghan por su excelente disposición y compartir su conocimiento con nosotros, ¿ya? Y finalmente quisiera invitarlos, ¿ya?, para que se unan nuevamente a nuestro ciclo de webinars el próximo 4 de junio a las 12 del día, en que presentará la doctora Ronnie Pressler la nueva clasificación de las crisis neonatales, ¿ya? Así que esperamos verlos ahí en esa instancia, ¿ya? Que muchas gracias y que tengan un muy buen día. Okay. Well. Well. Okay. We want to thank you again, Finbar. So thank you very much. I'm with you.
Really, thank you very much, Finbar, because we had a lot of questions, and you were really very clear with every question. So thank you again, and I hope we can continue talking by mail, and we hope you can come here after this pandemic we're living.
I would love to come to Chile sometime. That would be great. And thank you so much for inviting me to speak. Felipe, it's great to see you again. It doesn't seem like yesterday since you were on ward rounds in Great Ormond Street. So it's great to see you. And I'm really sorry I was a bit late getting here. I was racing back. I had a clinic I was doing a TS clinic in Bath, and I was racing back in the car, and I got stuck in a traffic jam. So please forgive my slightly late arrival, but it was great to talk to you, and I hope we meet again soon.
I hope so as well. So by the way, I sent you an email with the date of the last. I don't know whether you can see it. Could you say it with the brief bibliography of Bernardo Higgins and his Irish father?
I haven't yet seen it. I've got a lot of emails to get through.
You can, but it's very brief and explain why the son of an Irishman finishes as father of the nation in a Latin American country. So, but unlike UK, where your heroes rest in peace at St. Paul's Cathedral, our national heroes usually end exiliated, poor and abandoned, far from home. So it's a quite different story. So, but take a look at it. So.
I will. And Francisca, I'll write to you, because I meant to have some time before the talk to look at that paper again from the Americans about the 3 cases of vigabatrin toxicity. Yeah. And I've got a number of points to make about it, but I'll write to you about it. Yeah.
Yeah. Thank you. And finally, did you open the virtual gift?
It's in my email. I will open it.
When you have a time, you need to be relaxed and enjoy it, please.
Okay.
It's very, very beautiful.
Okay. Wow.
Okay.
May you have a very nice weekend. Thanks again.
Yeah, and you. Thank you so much, guys.
Bye-bye.
Bye-bye.
I'll see you soon. Take care.